We have with Dr. Kapil,
Yes, sir.
which is going to present on the topic. So, Kapil, you can share your PPT and we can start the
Yes,
class.
sir. Okay, so is my screen visible?
Yes.
Yes.
Okay. So good evening, everyone. This is Dr. Kapil Khandelwal from Holy Spirit Hospital, Mumbai, under the mentorship of Dr. Brushali Ponde, ma'am. Topic for tonight's presentation is block failure along with management and rescue blocks. We'll be covering the topic under the following heads. So introducing the topic. So why do we use regional anesthesia? It's more safer, it is more effective, and a core part of multimodal analgesia. Provides a lot of benefits like reduced opioid use. It leads to faster PACU discharge for the patient and has an increased patient satisfaction. The tools that we have to our disposal are ultrasound guidance, and that has significantly improved the success rates. Now, what is the challenge in a failed block? So even with ultrasound, failure rates still range from 5 to 15% depending on the block and the operator experience. A failed block therefore leads to patient distress, conversion to general anesthesia, increased opioid use, potential delays in the theater, and it demoralizes the anesthesiologist. So our goal is very specific and particular. It's timely detection and appropriate protocolized management. How do we define the failed block? A failed nerve block is one that does not provide the anticipated level of anesthesia or analgesia within an adequate time frame to allow the planned procedure to take place with adequate patient comfort without the addition of further unplanned interventions such as additional nerve blocks, systemic analgesia, sedation, or general anesthesia. Classifying the block failure, we have three types. The first one is a complete failure. It's no block effect whatsoever in the desired nerve distribution within the expected onset time, which is usually 20 to 30 minutes. That's the nerve soakage time. The symptoms here are absence of loss of any sensations to touch, cold or noxious stimulus. So there is no loss of sensation. There is still the block has failed. The primary cause here is a misplaced injection. It could be either intramuscular, intravascular, or it can be far from the nerve. In type 2, we have a partial failure where the block is achieved in some parts of the surgical field but is inadequate for the surgery to get over. The symptoms here are numbness present, but the patient reports breakthrough pain, often in a specific dermatome, which is here now called a patchy block. The primary cause of this is an insufficient spread of the local anesthetic due to anatomical variation or fascial barriers. The third type of block is the third type of block failure is a secondary failure. It's defined as when the primary block was successful, but the analgesic effect wears off before the surgery is complete, requiring urgent intervention. The cause here is that the duration of local anesthetic was inadequate for the procedure. It's important to note that this is a failure of the planning and not a technical failure of a block per se. Then comes neuraxial block failures. Here we have either a complete failure, which is no sensory or motor block for 15 to 20 minutes after
ఒకటి
injection,
పెట్టాం కదా బీరువా తలుపు తెరు
or a
బీరువా
partial failure where the block is patchy, one-sided, or insufficient for surgical incision. These were the different classifications of block failure. Now coming to the causes. We have an acronym called the PART or PART acronym, where P stands for planning or patient. So because of anatomical variations, because of pre-existing neuropathy the patient may be anxious and thereby not being able to give a proper position for the block or resistance of the patient to the local anesthetic. A stands for anatomy, which can have variations. There can be tough fascial planes or an unintended spread where we didn't expect the block to go. The R stands for regional block technique. So in technical errors, we have incorrect needle depth, we have poor visualization. The local may be deposited outside the fascial sheath or away from the nerve bundle, or technical errors of the local anesthetic where we've chosen the wrong drug or we've chosen the right drug but at a wrong dose or concentration at the wrong volume, or the drug itself is either defective or expired. Then comes T, that is timing. And this timing is very important. It's the soakage time of a nerve block, which is at least 30 minutes, at the max 30 minutes. So we have to wait for 30 minutes before declaring that the block has failed. Now, what are some of the causes of resistance of the patient to local anesthetic? So there are genetic and there are acquired causes. In genetic, we have mutations in the voltage-gated sodium channels where the local anesthetics act. In syndromic conditions, we have Ehlers-Danlos syndrome, wherein the patients are resistant to local anesthetics. In acquired factors, we have prior scorpion bites, is still a hypothesis, but is widely cited hypothesis. So due to antibodies that form against the venom affecting how local anesthetics work, the patient is resistant to the local anesthetic. Then we have anxiety and stress of the patient. This can increase pain sensitivity and make the anesthesia less effective for the patient. Coming to anatomical variations which may cause a block failure, we have variations in the origin of the roots and trunks of the plexus. For example, for brachial plexus, if it is prefixed, comes from C4 and ends till T1. Postfix starts at C5 and goes till T2. For variations in branching and course of the cords and terminal nerves, as examples, we have musculocutaneous nerve which may be absent, or a communicating branch may transfer fibers to the median nerve. The patient could have aberrant pectoral nerves, wherein the medial pectoral nerve may receive fibers from both the medial and lateral cords, or solely from the lateral cord instead of a typical origin from the medial cord. The ulnar nerve may receive a communicating branch from the lateral cord, and there could be variable nerve locations for individual nerves like median nerve, radial, or ulnar nerve. Then relations to vasculature and musculature, these structures, in vascular relationships, we have cords or trunks that may have an unusual relationship with the subclavian or axillary artery. And in musculature, we have nerve roots or trunks that may pierce through the muscles, like the scalene muscles, instead of passing between them. So to summarize the causes of peripheral nerve block failure, there are three broad categories. Either the needle is not in the right place for various reasons, either it's a drug problem, there's incorrect deposition, placement, or incorrect choice, strength, or volume, or it's a combination of both. Coming to patchy block. So the concept behind a patchy block, it happens due to anatomical factors or failure to plan the primary block correctly. So in order to give a correct block, we should know the dermatome, myotome, and osteotome of each block which requires to be covered. If it is not known correctly, it can lead to a patchy block. Another concept behind that is that a single nerve block may fail to cover the entire surgical field due to nerve branching occurring at proximal site than the block site. The solution here, it requires knowledge of the supplementary blocks. So now what are supplementary blocks? In upper extremity procedures, if we are blocking the brachial plexus, we may have sparing of the medial upper arm causing tourniquet pain. In this case, we have to supplement intercostal brachial nerve block along with brachial plexus block. For interscalene block, we can have sparing of the ulnar distribution, which can present as pain in the medial forearm and hand. In this case, we supplement the ulnar block at the axillary level or at the elbow or wrist level. For axillary brachial plexus block, we can have pain in the lateral forearm, which is the musculocutaneous nerve supply, which can be blocked separately thereafter. For lower limb procedures, if you are performing a femoral nerve block, the medial thigh of the patient, which is supplied by the obturator nerve, may be spared, which is why that has to be blocked separately. Another area that can be spared in a femoral block is the lateral thigh, which requires supplemental block for lateral femoral cutaneous nerve. For hip procedures, for the posterior hip capsule, a femoral nerve block may still not cover the whole area on the posterior side, wherein we'll have to give a pericapsular nerve group block or a sciatic nerve block. In proximal blocks, sciatic or lumbar plexus blocks, there may be patchy sparing in the foot and ankle area, wherein an ankle block would be supplemented. Coming to rescue blocks. Rescue block is an additional or subsequent peripheral nerve block performed to add or to replace an initial peripheral nerve block that has resulted in complete failure or inadequate or partial analgesia. Its features are that it's performed when the block is ineffective or partially failed prematurely. It is an unplanned intervention to address failure, and it is often challenging due to altered tissue planes because of the primary block. So what's the algorithm? What's the decision-making workflow algorithm for rescue block? So the first step is to confirm the failure of primary block. Unless and until that is confirmed, we don't go on to rescue blocks. After confirming the failure of primary block, now what we have to rule out is that the block has failed and not because of any other complication like surgical or hematological complication. After that, we have to evaluate the primary block site. We rescan the initial site and we re-evaluate whether the drug is in the right place or not. Then we identify the unblocked nerves to determine precisely which nerve distribution is missed. After this, we calculate the maximum dose for the patient because when giving a rescue block, both the initial and the second block dose have to be within the safe limits. So we have to calculate the maximum dose as with any block. Then comes the rescue strategy. We have two options here. One is a distal or a supplemental block which targets only the missed component, which is the better of the two. Or the second one, which is a high risk one, is a repeat block at a new or a proximal site. Since we've repeated a block in this case, a primary block followed by a rescue block, the post-procedure monitoring for local anesthesia systemic toxicity becomes very important. There are certain challenges we face during blocking for the second time. The initial local injection often causes tissue edema and disruption of the surrounding facial planes, making the target nerve difficult to distinguish from the surrounding hypoechoic fluid. For these, what weapons we have with us? We have a high frequency probe which has a better resolution and thereby it can make the anatomy clearer. It is advisable to use color Doppler so that we don't get confused by the hypoechoic drug or the hypoechoic vasculature nearby. We can use hydro relocation using dextrose 5% to try and relocate the nerves which may have been displaced by the primary block. The correct local anesthetic has to be used here. Since the surgery has started and there is a need for rescue needed, the rescue block has only to be covered for the remainder of the surgical procedure and not for the entire duration. Second important point in choosing the local is that since we've already given a good volume in the primary block, the rescue block has a priority of concentration over volume. So it has to be concentrated more anyway after injection. If it's in the same site, it will be diluted and the volume of the previous block will help. Then we can have additive agents like perineural or intravascular dexamethasone for that matter, or epinephrine should be added. Coming to some specific rescue strategies in upper limb. So if we give an infraclavicular or supraclavicular block, if it has failed, leaving the ulnar and musculocutaneous distributions. So we can block them distally. The ulnar nerve block, it can be blocked at the elbow or at the wrist joint. For musculocutaneous nerve, we can block it in the belly of the coracobrachialis muscle. The median nerve can be blocked at the mid forearm or at the elbow also. The high risk part of this is a repeat proximal block. These were the distal block, the median, the musculocutaneous, and the ulnar are the distal blocks since we are blocking them at elbow, forearm, or at the wrist level. Now, if we have to give a proximal block, it has to be given only if the entire plexus is needed and the initial block was clearly a technical failure. Or we can use a different approach in this case. For example, we can shift from an interscalene to supraclavicular approach. For lower limbs, if we're giving a fascia iliaca block or a proximal sciatic block that is ineffective, resulting in pain in the anterior or distal leg, we can repeat a fascia iliaca block if the initial volume was low or the spread was poor. We can consider blocking the lateral femoral cutaneous if the pain was solely on the lateral aspect of the thigh and was cutaneous in nature. And a sciatic nerve can be blocked distally, that is the popliteal sciatic nerve. This is safer as it is more distal site and it's away from the hip capsule. Other than that, for obturator nerve block failures, we can either have a pericapsular nerve group block or we can block obturator nerve individually. Coming to rescue of continuous peripheral nerve blocks. So when we have a catheter in situ and that is not working or we are suspecting that to be failed, we first have to check for the catheter integrity. Is there any kinking or is there any occlusion in the line or the pump? If the catheter is dislodged, do not attempt to push it back in. We decide to remove the catheter. If we have to rescue the block, that is if we have to reimplant the block or reinsert the block, it has to be inserted at a different adjacent site. For example, if the initial popliteal sciatic catheter has failed, you can reinsert it at a higher popliteal level or even a subluteal level. The bolus strategy here is if the catheter is intact, but the block is still inadequate, we give a small rescue bolus, which could be around 5 ml of 0.5 ropivacaine, that's a motor dose, before considering removal and replacement. There are certain contraindications and risks associated with rescue blocks. So there are absolute contraindications, that's patient refusal. In this case particularly, since we are doing a procedure for the second time, that's a rescue block, a second consent becomes very essential. The second absolute contraindication is a local infection at the second site. So where we are planning to block the where we plan to get the rescue block, this infection at the local site becomes contraindicated. And of course, with the combination of the second and the first block together, if the local anesthesia dose is exceeding the safety limit, we don't do it. The risk associated with rescue blocks are hematomas because of repeated needling and nerve trauma because of multiple attempts. Coming to neuraxial failure. So how does neuraxial failure occur and how is it dealt with? So at every stage of giving a neuraxial block, we can face difficulties and it can cause a failure. So when there is a problem with lumbar puncture itself, the issue is inability to obtain CSF, that's a dry tag. Causes here can be needle obstruction, needle placement errors, or patient positioning issues. The prevention of this would be proper positioning of the patient and use of ultrasound guidance wherever applicable. Now let's say we've got a good lumbar puncture, we've got CSF. Now there is still what other problems can we face? So we can face problems during drug injection. Issue here can be an incorrect medication, the drug itself is not right, incorrect dose, or loss of injectate while injecting. So there is no the connection between the needle and the hub of the syringe is not proper and the injectate is lost. The causes here could be swapping of drugs. So local anesthetic can be confused with another syringe filled with saline, or for that matter, local infiltration syringe can be used for subarachnoid syringe. There could be leakage at the syringe needle hub, and there could be a deposition of the drug into the epidural or subdural space instead of the subarachnoid space. So this was when we did get a good lumbar puncture, but still the block didn't work. Now the third situation is we got the lumbar puncture. There was no issue with the injection of the drug, but now there is an inadequate CSF spread. So the local does not spread sufficiently to cover the required dermatomes. The causes here could be incorrect baricity. So if someone's using a hypobaric drug in the wrong position, it can lead to inadequate spread of the drug into the CSF. Or the patient anatomy, the CSF volume could be variable or the spine could be curved and thereby leading to a inadequate inadequate drug spread. The prevention for this would be careful control of the local anesthetic volume, baricity, and patient positioning. The next stage where we could face problems is the failure of drug action. So we've got a lumbar puncture, we've got correct injection technique, the drug is in the subarachnoid space, it has spread evenly and properly wherever we need it, but there's still failure of action. So here the issue is that the local is present, but it fails to exert its effect on the nerve roots. The causes here now can be resistance to the local anesthetic itself, as we discussed earlier. It's extremely rare, but it could be a possibility. Or the drug itself is inactive, it's chemically unstable, or the drug is expired, thereby not leading to its action. Another important aspect of block failure in regional anesthesia is anxiety management in block failure. So anxiety can mimic failure. What action we have to take here is first of all rule out any technical failure before going on to anxiety. And if we rule that out, then we can manage anxiety of the patient with communication and anxiolysis. A calm patient is more likely to cooperate for a successful procedure by giving a good position and thereby reducing and minimizing the risk for failure. Now, coming to the management algorithm of a peripheral nerve block failure. The protocol involves the following phases. So we have three phases. First, there's plan A, which is the initial block, followed by phase 2, which is assessment of the block itself. If the assessment is successful, we go on to surgery. If not, then there is a phase 3, which is plan B, that's the intervention. So starting with phase 1, that's a planning of the initial block. So planning of the block has to be followed by the pre-procedure planning, the checklist that we have. This checklist has to be followed pre-procedure for any block. After following all the checklist and precautions of the block and then giving a block comes the phase 2, which is the block assessment, the critical 30-minute soakage time. You have to wait for at least 30 minutes after injection before diagnosing failure. What signs are we looking for while assessment? We're looking for loss of sensation to touch, cold and pressure. And objective signs are motor function testing and pain score on noxious stimulus. After which we reassess the block. Again, since we are deciding on whether to give a block again or not, it has to be reassessed. It has to be very thorough, must be detailed and systematic. The decision making goes as follows. If the block is successful, we go on with the surgery. If there is complete or partial failure, then we go on to plan B, which we'll read next. Or if there's a secondary failure, we go on to either sedation, general anesthesia, or if we have a catheter in situ, we go on with a bolus of that. The phase 3, that is the plan B, which has the intervention strategy. So now what important point decides whether we give the block repeat or not? So have we exceeded the local anesthesia safety dose margin? If we have not exceeded it, we may go for a rescue block. It's only attempted if the local anesthetic dose is below the toxic limit, the combined dose of the primary and the secondary block. Step 2 here is again systemic supplementation. We can have IV opioids and sedation. We can use ketamine and other analgesics for systemic supplementation of the block. The basic goal is to provide enough intraoperative time for comfort of the patient to finish the surgery. Now, if we have crossed the safety limit of the local anesthetic, the next step is to convert to general anesthesia. How do continuous peripheral nerve block catheters help us? So for secondary failure, what is secondary failure? The block, we've given a block, it has acted, but the duration of the action of the block was outlasted by the duration of the surgery. So the surgery is still going on, but the action is weaning off. Here we have continuous peripheral nerve blocks, which provide a superior management strategy as it allows for titration and bolusing of the local, extending anesthesia for several hours of the surgery and days of recovery. The risk here is that because it's a continuous catheter kept in situ, naturally there's more risk compared to single shot blocks. Crisis management. So we have an acute crisis. If there's an inadequate block intraoperatively, since we are talking about the neuraxial block, we first check the posture and the position of the patient. We can manipulate the position to encourage the spread if it is within 5 minutes. We can systemically implement the sedation or opioids. Local infiltration should be advised to the surgeons. If nothing works, the safest and the most effective definitive final step is conversion to general anesthesia. It is imperative to know that we do not repeat the spinal dose without a clear diagnosis of failure due to high risk of higher total spinal block. Since we are repeating a neuraxial block, the documentation here, as with any other block, becomes very important. Intraoperatively, you have to document all the attempts, the primary and the second attempt of the neuraxial block given, the total volume of the local anesthetic injected, the patient's symptoms, or rather the lack of symptoms after the primary block and the symptoms after the second block, the final block, and the final management strategy. Post-operatively, the patient has to be explained what happened and why was the neuraxial block repeated. So this was a suggestion by Ruchali ma'am. It's a very interesting thought, I thought. What are we really rescuing? Are we rescuing the patient from pain, or are we rescuing the block from failure? That's another important thing and a very interesting thing to ponder, that is it just the pain, is it just the block that we are worried of, that we are happy if the patient has a good block and everything goes well, or are we really worried for the patient? So if you're talking about the patient perspective, it also includes on-arrival blocks in either emergency departments or the wards. So rescuing the patient from pain is a more broad way of looking at it rather than just rescuing the block from failure. Summarizing the presentation, so failure is defined as a complete, partial, or secondary failure or inadequate spread in case of neuraxial blocks. In algorithms, we have plan A where we give the initial block, we assess it, and then we have plan B, which if plan A is failing, we give plan B, that's rescue. Rescue blocks are safe, avoided local anesthesia, toxic limits are respected, and our goal should be to make RA as predictable as general anesthesia. Bottom line is, conversion to general anesthesia is safe, valid, and a necessary option when all fails. And these are the references from where I've taken my content. Thank you.
Thank you, Kapil.
Okay,
Nice
sir.
presentation, nicely cover the topic. So the crux is we should not sure that we should not get panic when we are performing any block and it got failed. We should give a thought
Yes.
whether there is a failure or there is a inadequate time you are giving. So you have to wait up to showcase time like 30 minutes. Then you can assess and then you decide whether there is a requirement of supplemental block or whether there is a requirement of
Or a
rescue block.
rescue block. Yes, sir.
Yeah. So to differentiate whether there is a supplemental block failure or a total block failure and you need a rescue block.
Yes, sir.
And the crux is that there can be mainly, if you see, mainly there are three reasons. There either can be a technical, anatomical, and pharmacological.
Pharmacological. Yes, sir.
Yes, yeah. So things are covered nicely. Just I want to know, like you have told that a block failure in plan A is you will give showcase time, then you assess sensory, pinprick, temperature, then
Yes,
you
sir.
can check for sympathetic changes also. Then motor assessment, how you will do the motor assessment in upper limb and lower limb, which nerve is getting spared and which nerve is not, like which rescue block you want to give.
Okay, so are we talking about a neuraxial block or a peripheral
No,
block?
no, upper limb and lower limb separately. You are
Okay.
performing a peripheral nerve block, like you have block, given the brachial plexus block.
Yes,
Then
sir.
after 30 minutes waiting and then still some patients is having some movements. So how you decide which nerve is to be rescued and how, like which block to be rescued and how to give that block.
Okay, sir. So, sir, first when we've given a block, when we have to check for cutaneous distribution, we use a cotton swab or an ice pack. So that's for the temperature checking of the patient, and we check at the various dermatomal sites of the patient. So if it's a medial arm of the patient, that how accordingly we'll know if it's the ulnar distribution, or if it's a lateral, it could be musculocutaneous. So dermatomes that's how we decide for the dermatomes. For motor, we ask the patient to try and lift the arm from the shoulder joint in case of a brachial plexus block. So if the patient starts to feel heavy, or if the patient is starting to feel as if sometimes the patient say they feel there's a big rock kept on the arm. So which means that the muscles have started to give way and the patient's block has started to set in. If the patient is still able to lift the arm from the shoulder side, of course, the motor is not acting as well as we would expect it to, and we do not jump to this conclusion until we let the proper soakage time of 30 minutes pass. Of course, there
Yes.
are times when the surgeons may not want us to wait for that long. They may want us to rush with it, or they may want to, start painting and all. But
Yeah,
till the time of
that is,
incision, at least, I'm sorry, sir.
yeah, yeah, that is the role of a block room where you can perform the
Yes,
block and you
yes,
can wait for the showcase and
yes,
all.
sir. Yes, sir.
So there's the role
So
comes the block room.
yes, so that's the ideal scenario, which may or may not be
Uh,
available everywhere.
yeah,
Like we do at times give blocks we have a recovery room which we at times use as a block room. So we
yes,
can give block to the patient there. It has a monitor, it has the resuscitation
uh,
tray and the cart and everything. And if the theaters are running busy, ideally we have to block in the recovery or the block room,
yeah,
like you said. Wait for a showcase time, reassess the block. If needed, right there, we can give a repeat block or whatever other strategy, supplementary block ho gaya, rescue block ho gaya, and then shift in the patient. So, yeah, block room is the way to go in ideal
yeah.
scenario,
So
sir.
how you assess the motor blockage of the upper limb?
So for the motor block, we ask the patient to lift the arm from the shoulder area, and if the patient is still able to, so the
So how you decide which nerve to block? You are planning for rescue block, right? So how you decide which whether to give radial nerve block, whether to give motor nerve block, sorry, median nerve block or ulnar nerve block is required. You
okay,
remember we assess after giving brachial places, there is a how to assess the motor power and all. You remember the
yes,
pinch?
yes, sir.
So how you do that? So what is that? Tell. What is the inference from those techniques?
Sir, so for upper
Push,
limb,
pull.
yes,
Yeah.
push, pull, pinch. Right, sir, right.
Yes.
Yeah.
Yeah. What is that?
So for upper limb, we asked the patient to push our arm against resistance.
Yeah.
So that is
So
the pushing part of it. When we
yeah.
ask
What
the
is that?
patient to pull
So
our
what is
arm
that
against
inference?
resistance.
If patient is not able to push your arm, what do you mean by that? What happened? Which is pairing?
So when the patient is not able to push, so suppose the patient's arm is flexed and we are asking the patient to push our arm, which means the triceps are
Ah.
not able to contract. Or
Ah.
if, like you said,
So
the patient is able to push. So the supply of
not
the
able to
tricep,
push means which nerve is pairing?
so not able to push में patient का radial nerve will be spared
Yeah. So
and
we need
not
a
able,
radial nerve supplementation as a rescue block, right?
yes, sir. When patient
Yeah,
is
that's so
unable
good.
to push,
Yeah.
yes, sir.
And next is
And
pull.
unable, pulling में sir, then उसका musculocutaneous would be spared.
Yes.
Right?
Then
So
where you
when
will
we ask the
pinch.
patient to have the arm flexed and then pull, we are really actually testing for the biceps of the patient, biceps and coracobrachialis supplied by
Ah,
musculocutaneous.
yes.
So that is what we are looking for when we ask the patient to pull.
The other is pinch. Where you will pinch and check
So pinching is
which
for
nerve.
the dermatomal supply. So we pinch on various dermatomes of the patient that will give us the idea of the sensory distribution of the block.
For medial nerve, where you will pinch.
For medial nerve, sir, we pinch on the lateral aspect of the forearm. We check for the
That
patient
or the
from,
fingers.
yes,
Or
sir.
around the
For
fingers.
ulnar nerve, it's at
Index
the
and thumb.
medial part of the arm and forearm both, sir.
Yeah.
Yeah.
And
So if
similarly
there
for
is
lower limb.
for lower limb, sir, we ask the patient to again adduct the limb. So to begin with, we spread the legs of the patient. We rather abduct the limb of the patient. Against resistance, we ask the patient to adduct the limb. If the patient is not able to adduct the limb, which means the obturator nerve has been blocked, but if the patient is able to adduct the limb, the adductor rather compartment is supplied by the obturator nerve, which is spared in the case when the patient is able to do it.
Yeah.
Then when we ask the patient to lift the leg, we're looking for the anterior compartment. So we are testing for the femoral nerve.
So
If the
there should be
patient
a
is, I'm
flexion
sorry,
and
sir.
there should be a flexion at the hip and ask the patient to extend the knee.
Extend the knee. Yes, sir.
Yes.
Flexion
So
at the
that
hip and extend the knee, thereby checking for the anterior compartment, which is supplied by femoral muscles. I'm sorry, femoral nerve.
um,
And if we ask the patient to contract his quadriceps, his gastrocnemius, which is supplied by the sciatic nerves, that's how we look for the sciatic nerve sparing. If the patient is able to do it, the nerve is spared. If the patient is not able to do it, the nerve is involved. That is, the nerve is
so
blocked.
yeah. So you want to do it fast. So for that we have a mnemonic like push, pull, pinch. Same in lower limb we follow, but push, pull, pinch, punt. Remember, that
Yes,
is the
sir.
basic we do every time. Whenever you give motor block or something, you just give fast check whether patient is able to extend the knee. Then you check on the pinch on the for the LFC and on the lateral part of the thigh. Or
Yes, sir.
then you will ask the patient to pull the leg so that you will see the operator nerve. So those are the mnemonics so that it will be able to assess faster which nerve to block.
Yes, sir.
Okay, so like if there is a radial nerve sparing, where you will perform the radial nerve block,
So if there is a radial nerve sparing, we can
and you want to
block.
give as a rescue block.
Yes, sir.
Hmm.
So depending on where the procedure is, sir, if it's a procedure of the hand or the finger distal to the wrist, then we can block it at the anatomical nerve box mein where we have the radial nerve, we can block it there. If the procedure is proximal to that, we can block it at the lateral epicondyle of the humerus. That's where the radial nerve goes from arm to forearm. And at
Yeah.
a higher level, the
Above,
radial
at the
nerve
lateral epicondyle or above the lateral epicondyle?
above, sir. I'm sorry.
Above, not at the lateral. Above,
Okay,
where it
I'm
comes
sorry,
out
sir.
of the groove of the radial groove.
Radial
When the
groove,
nerve,
radial groove,
when
sir.
the
That's
radial
at the
nerve
mid
comes
shaft.
out of the, yeah. So
Yes,
when the
sir.
radial nerve comes out of the radial groove, lower shaft of the humerus,
Yes, sir.
at the
Yes, sir.
lower end of the distal nerve. Okay. And where you will perform the medial nerve block?
For medial nerve, sir, in the forearm, we can trace it very well from the axilla to the forearm itself. So medial nerve is very commonly performed and it's very well seen in the forearm also.
Uh,
And if it is a distal procedure, we can block it at the wrist as well, sir.
hmm. So
Yes, sir.
where at the elbow where you will block
Elbow, sir, medial nerve is at the
medial to the brachial artery. You will put a probe at the elbow and
yes,
find
sir,
out the
medial to
brachial
the
artery is
brachial
easy
artery.
to. So you will see the medial to the brachial artery.
Brachial artery, sir.
Yes. So similarly, ulnar nerve.
Ulnar nerve, sir, we can block it at the ulnar groove, which is at the just above the medial epicondyle of the humerus, which is at the
Yes.
posterior aspect at the elbow joint,
Mm, mm.
and tracing it downwards, even in the mid arm and at the
Above, yeah.
yes, sir, above
Just
the
to
epicondyle.
above the medial epicondyle, because in that the medial condyle, just there is a chance of sometime compartments and now will get more compressed, where there is a very less space between the skin and the bone.
Very less space. Yes, sir. It's
Okay,
going
so you
right.
will just block little above the medial epicondyle, right?
Yes, sir.
What is radial trinity block? Remember, you have
I'm
heard
sorry, sir.
about it?
Radial?
Trinity block.
No, sir. I'll make a
Recently,
note of it,
Amjad
sir.
Manyar sir has published it. Radial trinity block.
I'm not
Any of
aware
the
of it.
fellows, any of the fellows can put a fellows can tell which what is radial trinity block? Any of the fellows? I think nobody is present.
Vipin sir, Dr.
Uh,
Ashwin has messaged radial, median, and lateral cutaneous nerve of forearm.
Aishwarya, you can unmute yourself and answer the question.
yeah, that will be a better. In, anybody can unmute and answer. Aishwarya, you want to answer?
Yes, sir. It's the
Yeah.
combination of radial, median, and lateral cutaneous nerve of forearm. I
How you
think.
will block?
Uh,
Where you will block? Which part of the hand? What is the process? Like how you will
yeah,
perform this block?
uh,
So in
just
this you will
at
put up
elbow.
yeah linear probe
Near
at
the
the elbow or at the
at the
crease
elbow,
of the elbow.
above. Yes, sir.
Identify the
Distal to the.
brachial artery
Yes, sir.
and then you identify the medial nerve at the medial to the brachial artery. Then LFC and the sorry lateral cutaneous nerve will identify where you will what is there in the middle
And
of
that
cephalic
will
vein.
become subcutaneous. Distal to the elbow crease, the that nerve will become subcutaneous. So
Uh,
it will be like medial to the cephalic vein. I'm not sure.
okay. So you have to see the cephalic vein and you have to block nerve. Which nerve you will block next to cephalic vein?
Lateral cutaneous nerve of forearm, sir.
Yeah. So and then for radial nerve, you will block where after bifurcation of brachial artery or before bifurcation.
Uh,
Or bifurcation, sir.
before
Yeah, before bifurcation.
Before bifurcation.
You will miss the anterior
Yeah,
interosseous nerve, right?
yes, sir.
Yeah. Hetal sir, any other questions you want to ask?
Yeah, very nice presentation by Kapil. I mean, so Kapil, basically to understand the anatomy is first important thing to before going. I mean, to know the block failure, and second most important part is how to assess the nerves. It is very important to know which nerve is failed before going for rescue blocks. As Dr. Vipin has said, you have to assess the block before ask the surgeon to proceed for the surgery. So always assess the block before asking the surgeon to proceed for surgery. And very important part is to understanding the anatomy. If you don't understand the anatomy, you will definitely fail. Suppose if you are going for shoulder surgery, you have given. I have seen many anesthesiologists only giving interscalene block or supraclavicular block, and one surgeon puts the incision on the lateral side of arm, patient will complain of fail. So will you consider it as a failed block or you are missing something?
No, sir. Supplementary block has to be given in this case, sir. We are missing it. We are not.
Which supplementary block?
Sir, so we've given interscalene block, right?
Yes.
So,
And incision is on the lateral part of shoulder.
sir, in this case, we can give a supraclavicular block, sir, because that would be a supplementary block to interscalene block in this case,
Yeah, so
which we may have.
that's why we have described. I mean, Dr. Shiva has describes cut block. That is superficial cervical plexus as well as upper trunk block.
Upper trunk. Yes,
So
sir.
if you are giving interscalene block, you have to supplement it with superficial cervical. So if
Cervical
you don't
plexus.
know about the anatomy, which is the dermatome, which is the myotome, which is the osteotome, then patient will complain of pain and you will start giving GA. So you have to understand either you give superficial cervical plexus block or you can ask the surgeon to infiltrate at the incision site and that will complete the block. Same way if you are doing elbow surgery, sometimes posterior cutaneous nerve of forearm is, I mean, arm is paired and patient will complain of pain as such as soon as you put the incision. Suppose patient has surgery in the lower end of the radius, and if you have given individual nerve block like radial nerve block, ulnar nerve block, median nerve block, which nerve will be spared?
Sir, so radial cutaneous nerves would be spared in this case, sir. So,
Which nerve?
so we've given individual blocks, right?
Yes,
So
we
the
have given
cutaneous
radial nerve
nerve,
block, ulnar nerve block, and median nerve block. So which nerve is spared?
so the cutaneous nerve, the posterior cutaneous nerve of the forearm would be spared in this case, sir.
And any other nerve?
Musculocutaneous.
Medial and posterior, sir.
Medial or lateral?
So
It is lateral
La-
cutaneous nerve of
lateral
forearm, and lateral cutaneous nerve of forearm is branch of.
musculocutaneous.
Very good. So it is branch of musculocutaneous nerve. So you have to know which nerve is paired and why patient is feeling pain. So you have to supplement the block accordingly. You have to choose the block accordingly. And I've seen many people don't understand the anatomy, start giving blocks, and they fail because they have given wrong block, because they don't know about osteotome, dermatome, and myotome. Another important point is LA resistance. Can you tell me the causes of LA resistance?
Sir, so causes to local anesthetic in genetic causes, we had the resistance of the patient, the
Most important in our rural area.
so most important or the most common would be venom, sir. So scorpion bite is what
Exactly. So you have to ask for the
yes,
scorpion
sir.
bite history when you see the local anesthetic is not working. Another is patient with hyperextension. I mean hyperextensive joints. If you see the patient with hyperextensive joints, there are chances of. There is a study where they found that in such cases there are chances of local anesthetic resistance.
Yes, sir.
So you have
That's
to
the
look for the
Ehlers-Danlos
causes of
syndrome, sir.
rather than blaming the drug. Most of the time when we see the failed spinal, we blame the drug. Like ये बेच ठीक नहीं है करके छोड़ देते हैं. That is not really the cause. And in fact, Extra did a study when they got such complaints, and it was perfectly fine.
Fine.
And it was failure was because of technical errors or some other reasons, and it was not the drug. So don't blame the drug. Look for your technique and look for sometimes your anatomical knowledge. Rushali ma'am, anything from your side?
Yes, yes, just a thought that crossed my mind, especially when you were quizzing Kapil about knowing the anatomy and what must and the pre-planning of it is with your shoulder case. Imagine that you are in the OT, all dear students here. Imagine you are in the OT and you're pretty happy with all the pain relief that your block has instantly given. But somehow you have missed something, and the surgeon does take an incision, and then the patient does complain of pain. That is the time when you're really going to feel so demoralized, as it were, standing at the head end. That is the time, if this happens, that is the time you have to stand up for yourself, respectfully claim that there is a sparing. At that time, don't try and hide that your yes, your block is fine, and quietly give midazolam, ketamine, propofol, so on and so forth. Tell the surgeon why this has happened, if at all it is. Reassure the patient. Do what is needful, if at all this happens after the incision. So, in other words, own a failure, respect it, try and see what you can learn out of it. And Hetal mentioned one more point. It's a very good habit to ask your surgeon to infiltrate the incision area, because there are certain nerves, no matter how wonderful a brachial plexus block you give, you're not going to get them. Typical example is the intercostobrachial. So keep this in mind, how to conduct if this is what happened. This is what actually happens in the OT.
Yes, ma'am. So basically, anatomy should be thorough so that you know whether to use a supplemental block or whether to use a rescue block. If you know the anatomy, you can decide whether it is a. So for that, you have to be proper assess the block after performing. There is a question in the chat box. Uh, Please explain how posterior capsule sparing can be rescued by the pen block. Kapil?
Yes, sir. Sir, so recently there was a peng block for the posterior capsule described. So the peng that we use is for the anterior capsule, right? Because
Yes.
we have the patient in a supine position. We go for the iliac crest, we go for the ASIS, and then we go medially. We look for the iliopubic eminence, and that's where we deposit the drug in the trough. So that's for the anterior capsule. And recently there was a posterior pericapsular nerve group block described. I will look up the article and share it, sir. But they have described the peng block for the posterior
Yeah.
capsule as well.
So there are 2 or 3 blocks recently they have described in which they have targeted the nerves which are
Yes, sir. Yes, sir.
supplying the posterior capsule.
Posterior
They're called
capsule.
posterior capsule compartment block. One is, and one is there are one more block they have told. So that is they are targeting all the nerves, the branches of sciatic nerve which are supplying the posterior capsule.
Yes, sir.
So they will give around the capsule. They will infiltrate the drug so that the nerves coming from the branches coming from the sciatic nerve or nerve to quadratus femoris, those will get blocked here. Okay. So one more is, does operator nerve get blocked in pen?
So there are branches of obturator nerve which do get blocked in peng. So in peng we have the nerves coming from the hip to the leg, and those nerves which are crossing the joint capsule are blocked. Obturator nerve, not the main nerve, but there is a branch of the obturator nerve which does cross that area and is blocked by the anterior peng block, sir. And anterior
They,
capsule ka peng block.
they'll tell there is a chance of getting accessory operator, anterior branch of operator
Yes.
might get blocked by forming the pen. Or that also depends on volume and the needle position, whether your needle is more medial or towards the femoral artery, like you have crossed the tendon, you are more medial to the psoas tendon, then chances are that it will get
Yes, sir.
blocked.
It
Or if you
crosses
use
from medial
higher
to
volume,
lateral. So
yeah, and if you are using higher volume, then I think all other there is no other question. If the axillary block failed, can it be rescued by forearm block?
sir,
Kapil?
since yes, sir.
Tell me.
Sir. So individual nerve blocks at the forearm, if we can manage to block, and depending on where the failure has happened, which nerve ka failure has happened, we can cover it with the forearm block.
Yeah. If you are using ultrasound, if you have not used much of volume, then you can
Yes,
scan at the axillary level only, and again you have to infiltrate there. If you are not able to see or patient is not giving proper position and you are still a view is not good, like window is not good, and you are not able to identify the nerves properly at the axillary level, then you can go at the forearm and
at
perform
the
the
forearm.
block. And despite like surgery should be at the distal to that, like either in the hand or fingers or forearm, distal forearm, radial lateral. Yes. So there are anatomical variations are there, Kapil. What are the anatomical variations can be possible?
So in anatomical variations, what we have is the brachial plexus itself can be either prefixed or postfixed. So the prefix meaning it comes from a level higher. So in this case, from T4 it can originate. And if you're not looking about, if you're not attentive of that, we may miss it. Or in case of a postfix, it leaves from the T5.
Hmm.
It ends at, sorry. Then apart from that, sir, the pectoral nerves can have an anatomical variation. So
Yeah, that is there, and the chances are that there will be an interactions like medial nerve is giving branch to the ulnar
yes,
nerve
so
is
the
giving distally
branching,
and medially. There are some names are also given to them. Like if the proximally medial nerve is giving one branch to the ulnar nerve, and that will can cause so that can be a chances of sparing there.
yes, sir.
So do we add adjuvant in the rescue block if we have already used it in the primary block?
No, sir, we don't because like the adjuvant,
So
okay.
it depends on the duration of the surgery, right?
Yeah.
So if you have added the adjuvant there, if you have hospital protocol is there, you are adding perineural adjuvant. If you are, some hospitals are not doing this perineural injection. If you are using adjuvant there, and if it is sparing is there, and you want to do surgery, and you know that peripheral nerve block, if you are giving volume 4 ml, 5 ml, so then duration you have to prolong the duration. Then you might have to use the adjuvant because
Adjuvant.
you want to prolong the duration. So if surgery is going for 1.5 hour, 2 hours, and then you are now using concentration, but it is not giving you adequate time, so you won't again ask the surgeon to stop the surgery in between, right? So better to give adjuvant at that level so that the surgery can be done without any interruptions. In repeat block, do we give higher concentration of LA?
Yes, sir, it is advisable to use a higher concentration because if you're repeating the block, if you're repeating the same block, we have the initial drug as well. The primary block drug is still there. And the higher concentration in this case would help dilute the drug with the initial volume of the drug that's already present.
Yeah.
And because we
Yeah.
can't give more volume in this case, we have to give the same, if we have to have the same effect in a lower volume, thereby the concentration does go up, sir.
Yeah. Any other question from any other faculties or any fellow want to ask any question?
Dr. Bipin, Dr. Anshuman this side.
Yeah. Yes, sir. Tell me, sir.
Uh, Actually, I wanted to know, suppose you have patients where you only patient is in a frail patient. Suppose you're doing some phrenic sparing blocks or shoulder surgery or some mastectomies. So in these patients, choosing a judicious nerve block is more important to get an effect, because in these patients usually you do not have the option of putting a second nerve block. So the volume, concentration, and the dermatomal and myotomal things needs to be very clear before planning a nerve block. And the discussion with the surgeon is very important before you decide about the incision and all those things and the which
Yeah,
block you need to give.
yeah, there
So
then the
usually,
anatomy comes.
and usually what we do is that if we are doing it solely under block, we always ask the patient, the surgeon to do a pinching before they start painting and draping. And if you have an option of putting the block before the outside the OT, then that also helps a lot, because that gives the time to set in, and when they move the patient to the OT table and put in the monitors, the block has already taken effect. So that gives a lot of time to find out whether the block is effective or not. Otherwise, we can just add on the other things what is necessary.
So if any other faculty wants to give input,
Any other questions from
Yes, yes, yes.
fellows?
Dr.
Do we
Bipin,
have a
Dr.
quiz today?
Dr. Bipin, I have already shared that that posterior
Yeah,
capsule, that block, that article I've
yes,
shared in the
yeah.
group already.
Okay, okay, sure. Dr. Sangmitra, do we have a quiz today?
No, sir, the topic was covered in last session only. Today we don't have any quiz, sir.
Or can we wrap up then?
Yes, yes, please.